how and why drugs become addictive. Should be an interesting chapter, I hope. Here we go. Psychoactive drugs are substances that directly affect the central nervous system. The method that a drug gets into the brain are called pharmacokinetics. Literally, drug movement. How are they absorbed? How are they distributed? How are they metabolized? And eventually, how are they eliminated? Pharmacokinetics, the route of administration, the speed of transit to the brain, the affinity for nerve cells and neurotransmitters. When a psychoactive drug can get to its target in the central nervous system rapidly, the more addictive it tends to be. Inhaling, when a person smokes a psychoactive substance or draws it in as a vapor, as with the nitrous oxide, or inhaling an active chemical solvent, colloquially referred to as huffing, the drug enters the individual's lungs. The drug rapidly absorbs through the capillary lining of the alveoli of the bronchi. The psychoactive substance travels through the body with the blood and is pumped to the brain and the tissues of the body and may reach the brain in as short as 7 to 10 seconds. Inhaling is the most rapid method of getting a psychoactive substance into the system. Individuals are able to control levels and reactions of psychoactive substance, known as titration, by regulating the frequency of use and the depth of inhalation. This is why most tobacco smokers spend more time holding their cigarettes than actually puffing them. Since smoking is an inefficient means of administering the psychoactive properties of marijuana, the THC, 60% of the substance is lost. Pharmaceutical companies are working on aerosol and nasal sprays to deliver the THC, and two of these are Marinol and Dronabinol. This method would also eliminate the tars and other toxic substances that make marijuana carcinogenic. Injecting is where the individual introduces a psychoactive substance into the body by using a hypodermic needle and syringe. There are 3 methods of injecting appropriate psychoactive substances into the body. Intravenous, or into the vein, colloquially known as slamming, is where the psychoactive substance is injected directly into the bloodstream. This method delivers a psychoactive substance through the bloodstream into the brain in about 15 to 30 seconds. This method is most likely to create a head rush, an intense feeling of excitation, and mental electricity. Intramuscular, into the muscle, colloquially referred to as muscling, the psychoactive substance is injected directly into the muscle. This method of introducing psychoactive substances through the bloodstream and into the brain in 3 to 5 minutes. This method will not create a head rush, but a slower buildup of euphoria. Subcutaneous, under the skin, colloquially referred to as skin popping, the psychoactive substance is injected directly under the skin. This method of introducing psychoactive substances through the bloodstream and into the brain in 3 to 5 minutes. This method will not create a head rush, but a slower buildup of euphoria. And that's what it does to you. It causes abscesses. I had a friend that was a skin popper, and he looked just like that. He had those all over his arms. Injection is the most dangerous method of introducing drugs into the body because once they are entered, there is no turning back. Injecting also introduces the user to a whole host of contaminating infections such as hepatitis B and C, syphilis, and HIV. The individual is also more prone to abscesses and embolisms, blood clots. Now, this guy looks dead, but he's not. You can tell he's too pink. Mucous membrane absorption. Select psychoactive substances that come in a powdered form can be inhaled through the nose and absorbed in the capillaries found in the mucous membranes. You can do this with cocaine, with heroin, with methamphetamine. You can grind up OxyContin and snort it. This method is much more rapid than oral ingestion and bypasses most of the body's defenses, the digestive acids, enzymes, and the liver. Besides snorting through the nose, there are two other methods used: buccally between the gums and cheek, like snuff, and sublingually, or snooze. You guys don't call it snooze, but up north they call it snooze. Sublingually, under the tongue. This is how you administer nitroglycerin. You have to put it under the tongue. If you let them swallow it, it gets destroyed in the stomach juices. Absorbing drugs through the mucous membrane in the rectum and the vagina are also possible. This is usually administered as a suppository, but can also be used for recreational drugs such as ketamine and cocaine. I have known cases of individuals that would soak tampons in vodka or tequila and put it up into their vaginal areas and get drunk really, really fast. This is a real picture. This guy has stuck an aerosol can into his rectum for some reason, and it got stuck, and he couldn't get it out. So he had to go in. I've seen these in the emergency room. They're some of the nastiest stories you can possibly imagine. But anyway, this guy has done this with an aerosol can. Strangely, you can do it with just about anything, as weird as that may seem. Oral ingestion: when a drug is swallowed, it goes through the esophagus into the stomach. It passes into the small intestine, where it is absorbed by the capillaries in the mucosal lining of the intestine. This method requires between 20 and 30 minutes before the drug begins affecting the brain. So if you take a pill, it should take it about 20 to 30 minutes before it actually starts working. If the psychoactive substance is a beer or other alcoholic beverage, about 10 to 20% of the substance will be metabolized by the stomach. Males tend to metabolize alcohol faster than women and thus get drunk slower than a woman who consumes the same amount of liquor. Most psychoactive substances are fat soluble and so move readily across the membranes. Alcohol is both fat and water soluble, and that's one of the reasons why you get drunk so fast. But I wouldn't, well, it looks like he's throwing up in a urinal. How cool. Transdermal absorption: drugs are now being impregnated on adhesive patches so that the medication can be slowly absorbed through the skin. Some of these patches provide medication for up to 7 days, though it may take as long as 2 days before a therapeutic level of the drug makes it into the system. Because of various factors, psychoactive substances in the blood do not remain in the system for the same length of time. This is known as bioavailability. There are various factors that restrict the availability of the psychoactive substance to the target tissue after administration. Once a psychoactive substance enters the bloodstream, it can be transported inside blood cells in the plasma by attaching itself to a protein molecule. The psychoactive substance will visit every organ in the body where it will cause an effect. It will be ignored. It will be stored, usually in fat cells. It will be biotransformed, broken down into chemical variations that may or may not cause psychoactive effects. While the chemical structure of the drug is a factor in distribution, so is the size of the individual. A lighter person with less blood volume will have less blood to dilute the chemical. The blood volume of an adult is 6 to 8 quarts of blood. Children may have 3 to 4 quarts of blood. Organs with extensive vascularization will be affected by a drug to a greater degree. This is one of the reasons why cocaine can cause fatal heart reactions. Too much of the drug affects the highly vascularized heart, causing arrest. Humans would have died from bacteria, viruses, and toxins at the beginning of our evolution if it weren't for our ability to keep most of these substances out of our central nervous system. The walls of the capillaries that feed the nervous system consist of tightly sealed epithelial cells that only allow certain substances to penetrate. This is known as the blood-brain barrier. Luckily for those who need a chemical assistance on their lucidity, psychotropic medications do cross the blood-brain barrier and change serotonin, GABA, or whatever other neurotransmitter we're dealing with to reduce the symptoms of depression, anxiety, or whatever. The chemicals that people use as psychoactive substances also will cross the blood-brain barrier. Otherwise, they wouldn't be taken since there wouldn't be a brain reaction to them. The reason psychoactive substances cross the blood-brain barrier is because the brain is very fatty, and most psychoactive substances are fat-soluble or lipophilic. This is the case with nicotine, alcohol, and marijuana. And this is how long these drugs take to clear the system. You'll have amphetamines in your system for 2 to 4 days, barbiturates 4 to 7, benzodiazepines 3 to 7, cocaine 2 to 4, ecstasy 1 to 3, methadone 3 to 5, methamphetamine 3 to 5, opiates 2 to 4 days, opiates. Oh, this is morphine. This is other opiates 2 to 4 days. Phencyclidine, PCP 7 to 14 days. THC will stay in your system for as long as 30 days, 2 weeks to 30 days. Tricyclic antidepressants, 7 to 10 days. Propoxyphene, 1 to 2 days. Oxycodone, 2 to 4 days. Amphetamines, 2 to 4 days. Cocaine, 2 to 4 days. Methamphetamine, 500 nanograms per milliliter, 3 to 5 days. Drugs that are completely fat-soluble will cross the blood-brain barrier very rapidly. Drugs that are only partially fat-soluble will cross the barrier much slower. This is the case with morphine, which crosses the barrier much slower than heroin. This form of crossing the barrier is known as passive transport. It has to attach itself to a protein. Active transportation takes place when a water-soluble or hydrophilic chemical needs to cross the blood-brain barrier. A water-soluble chemical must first attach itself to a chemical structure that will readily cross the barrier. In the case of cocaine, cocaine hydrochloride attaches itself to a protein molecule. Most water-soluble substances, such as antibiotics, will not cross the barrier. The blood-brain barrier does not completely develop until the individual is 1 or 2 years old. Toxic chemicals that will not injure adults cross an infant's barrier and cause brain damage. The placental barrier protects the developing fetus from water-soluble chemicals. But since most psychoactive substances are fat-soluble, the fetus uses whatever the mother uses. There you go. Just drink that wine, lady. You're feeding your kid wine. The body is always trying to rid itself of foreign substances, whether they are harmful or helpful. It does this in 2 ways: metabolism and excretion. Metabolism is processing, using and inactivating a substance. Most of it takes place in the liver. Excretion is expelling the foreign substance and its metabolites from the body. This takes place mostly in the kidneys. When the liver metabolizes alcohol, it breaks it down into water and carbon dioxide and excretes it from the body through the urinary tract, sweat, and as vapor from the lungs. And if you've ever worked in the emergency room where somebody came in snockered, oh boy, you can smell it on their breath, you can smell it in their sweat. The liver breaks Valium into 4 metabolites that are actually active in themselves and affect the brain. This is Lindsay Lohan, and for the longest time she had a drinking problem. The measurement of the, I don't know if she does anymore. The measurement of the metabolism or elimination of the chemical is the half-life. It takes 6 half-lives to break a chemical down so that it isn't detectable. Cocaine's half-life is 30 to 60 minutes. It's detectable for 3 to 6 hours. Methadone's half-life is 15 to 60 hours, detectable up to 15 days. THC, the half-life is 20 to 30 hours. It's detectable for 5 to 7.5 days. Prozac, its half-life is 1 to 6 days. It's detectable for 6 to 36 days. Clearing the system is based on many factors, so none of these figures are absolutes. And that's the reason why there's such a vast discrepancy between how long it takes to get something out of your system. Age is a factor in metabolism of drugs. After the age of 30, the liver begins producing fewer and fewer enzymes to metabolize select chemicals such as alcohol and the sedative hypnotic drugs. Race has been shown to be a factor in levels and types of enzymes maintained in the liver. Caucasians tend to maintain enzymes used to metabolize alcohol rapidly, while Asians metabolize alcohol slower and with more side effects, quicker drunkenness, and a rapid flushing of the face. Hereditary factors can affect metabolism. Some people inherit fewer enzymes. Some people inherit more body fat to store drugs. Some people inherit a high metabolic rate to help eliminate drugs. Health can affect metabolism. Unhealthy people tend to metabolize chemicals slower or less completely. For example, the individual may have severe liver damage due to hepatitis or cirrhosis. An individual's emotional state changes the effects of the drug. Anger or anxiety in a person using methamphetamines may cause episodes of lashing out or violence. The presence of other drugs will delay the metabolism of select drugs. When alcohol is used with Xanax, the Xanax will stay in the body 2 to 3 times longer than normal. This delay of metabolism and exaggeration of effects is called drug synergism. Not everyone's body chemistry is the same. This is why some people are allergic to select drugs and others aren't. Some people lack the enzyme that metabolizes cocaine, so even a small amount in the system will result in an exaggerated reaction and even death. And I think I've told you about my strange drug situation. I can't take opiates because they don't work on me. They don't do anything to me. You got to knock me out with a hammer, just about. I've had surgery where they had to double dose me, give me 2 boluses of fentanyl and morphine. Other factors that can affect the metabolism of a psychoactive drug: weight, level of tolerance, monthly hormonal cycle of a woman, enzyme induction, enzyme inhibition, and weather, strangely enough. The lower the barometric pressure, the more it forces things through your body. So one of the things that may happen to you if a storm is moving through, you may have to urinate more frequently because your kidneys, it forces fluid through your kidneys faster, as weird as that sounds. In order to understand the effects that psychoactive substances have on the nervous system in general and the central nervous system in particular, we need to review the various nervous systems that control our bodies. The nervous system can be divided into 2 parts. The central nervous system, which consists of the brain and spinal column and controls most nervous responses, and the peripheral nervous system, which encompasses all other nerves outside of the central nervous system and communicates impulses to the central nervous system. The peripheral nervous system collects information, sends it to the central nervous system, which then responds to the stimulus back through the peripheral nervous system. The proper response will be through the appropriate system of the body: the nervous system, skeletal system, endocrine system, digestive system, respiratory system, muscular system, circulatory system, urinary system, lymphatic system, and integumentary system, which is your skin. Psychoactive drugs may alter information headed for the brain. Painkillers block the chemicals that tell the brain that they are in pain. Psychoactive drugs can disrupt messages sent back to the parts of the body when someone is so drunk that their hands and feet don't work properly. Psychoactive drugs can disrupt thinking. There you go, alcohol again. Psychoactive drugs may affect an organ when they pass through it or affect them when the central nervous system sends back a distorted message. Evolutionary psychologists speculate that any changes in the human form, including the brain, continued because they assisted the individual in their survival. A good example of this is the human affinity for sugar and fat, which provides a quick and more prolonged energy source. Another example would be the affinity for sexual intercourse for both males and females, which would lead to offspring which guaranteed the survival of the species. Following the evolutionary premise, psychoactive substances must serve some purpose. One reason may be that most psychoactive substances affect our natural survival mechanisms, but initially cause desirable effects. Eventually, as humans, we may adapt to the effects of these substances, but as for now, these substances are subverting our survival mechanisms, and in many cases, the result is anti-survival. The human brain not only maintains the largest cerebrum, new brain, of all the creatures, but all the structures of the lower animals. That's the old brain. As survival became more complex, higher animals forms developed new brain structures to aid them with survival. The primitive primal or old brain consists of the brainstem, the cerebellum, the midbrain or mesocortex, and the limbic system. These brain structures can be found from animals as primitive as fish to humans. The old brain regulates physiological functions, respiration, that's the brainstem, heartbeat, the brainstem again, body temperature, the brainstem again, hormone release, hypothalamus and pituitary, and movement, and that's the cerebellum. And this is the brainstem. What else? Hypothalamus is right here, and this is the pituitary. And that's the cerebellum. The old brain, the limbic system, is the area that acknowledges experience of basic emotions and cravings: fear, anger, hunger, thirst, lust, pain, and pleasure. The old brain is the area that imprints survival memories, specifically the limbic system. Most psychoactive substances act on the old brain, causing euphoria in this area, and thus providing the euphoric memories that lead to addiction. The emotions of the old brain overpower the reasoning capacity of the cerebrum, and lead to the repeated taking of euphoric substances. So the cerebrum tells the body not to do it, but the old brain is saying, but it feels so good. As hominids advanced over time, more and more brain power was needed to survive. This came to us in the form of the cerebrum and the highly convoluted neocortex. The new brain aids us in solving the problems of survival. Most of the time, the new brain controls the old brain. Reasoning trumps emotion. However, when a person uses psychoactive substances, the craving from the old brain may override rational arguments. It's too expensive, it has bad side effects, it's dangerous, I have other responsibilities that are more important than my pleasure. But of course, sometimes the old brain overrides the logic of the new brain. The reward reinforcement pathway encourages a human to perform or repeat an action that promotes survival. It is this pathway that is affected by psychoactive substances. Also referred to as the mesolimbic dopaminergic reward pathway, it has a stop switch, the orbitofrontal cortex, and a more switch. The more area is also known as the pleasure center and encompasses four structures: the amygdala, the lateral hypothalamus, the nucleus accumbens septi, and the ventral tegmental area. The pleasure center serves two purposes. It gives a feeling of satisfaction when a need is fulfilled, or even the anticipation that a need will be fulfilled. It gives a surge of relief or intense satisfaction when a pain is diminished. Psychoactive substances activate the pleasure circuit and rewards the individual with a feeling of satisfaction or pain relief. Unfortunately, psychoactive substances overactivate the pleasure center and shut down the stop switch, enabling the individual to feel an intense need to continue use. 3 phases of brain activity with the reward reinforcement pathway. 1, the anticipation of drug use or compulsive behavior creates craving. Internal or external cues activate the amygdala, which causes a release of the dopamine from the ventral tegmental area, which in turn activates the nucleus accumbens, causing craving. For an alcoholic, passing a bar external cue, which activates the amygdala, causing a release of dopamine from the ventral tegmental area, which would activate the nucleus accumbens, causing a craving for alcohol. For someone who smoked pot with their friends before they went away to school, when they see their friends on spring break, it's an external cue. It would activate the amygdala, causing a release of dopamine from the ventral tegmental area, which would activate the nucleus accumbens, causing a craving for pot. The second phase, the reward reinforcement pathway, involves the brain telling the individual to do it again after ingesting the psychoactive substance. With use, dopamine is released from the ventral tegmental area, which activates the nucleus accumbens to continue the craving. Phase 3 of the reward reinforcement pathway involves the nucleus accumbens signaling the orbitofrontal cortex that it has taken in the substance and asks for a signal of more or satiation. In addicts and abusers, this signal is weakened, as is the reasoning function of the area, resulting in ingestion that does not lead to satiation. Psychoactive substances imprint the memory of euphoria or pain relief more deeply than most natural survival memories. The alteration of brain chemistry causes normal activities to be less pleasurable. To the methamphetamine addict, the desire for the drug will be more important than her relationship with her children. To the compulsive gambler, gambling will become more important to them than food or sex. Psychoactive substances tend to affect the physiological functioning of the body, especially heart rate and respiration. It is the effect on respiration that causes most drug overdose emergencies and death. Psychedelics, LSD, marijuana, the rave drugs, not only affect the old brain, but the new brain as well. These drugs especially affect memory as they activate 2 areas of the brain that help to control memories, the amygdala and the hippocampus. As people age from childhood to adolescence to adulthood, they learn to integrate the drives of the old brain with the reasoning and common sense of the new brain. Developmental problems, childhood traumas such as chaotic or abusive childhoods, compulsive behavior, or psychoactive drug use can circumvent survival mechanisms and lead to irrational behavior or addiction. The most important structure of the reward reinforcement pathway is the nucleus accumbens septi. This bundle of nerves is the most powerful reinforcer in the pathway. It is this area of the brain that drives people to action. Research with rats stimulating this area of the brain led to death. They could do nothing else but stimulate this area. Human subjects who stimulated this same area behaved in a similar manner to the rats, but they didn't die, of course. They didn't allow them to die. Social factors tend to affect the obsession to use a psychoactive substance. The psychoactive substance alters the brain chemistry to make the individual want to use. This is one reason why only complete abstinence will stop the craving. To begin again will lead to the craving starting at the same intense level. Brain imaging has shown that brain cells change as addiction develops. While normal memory doesn't take place until an action has been repeated 3 or more times, intense stimulation can cause sensitization with just one encounter. These neural pathways are highly sensitive and may cause relapse in just one additional encounter. Why do psychoactive drugs disrupt the on-off switches of the reward reinforcement pathway? One theory is that since they don't originate from the essential body need, the brain has no satiation point established for psychoactive substances. A second theory is that the on-off switch gets stuck in the on position. The person doesn't realize that the act has been completed. The person will use until they run out of the drug or pass out. A third theory is that the psychoactive drug creates such euphoria or pain relief that the on-off switch is ignored or overridden by the brain. A fourth theory is that the psychoactive substance disrupts communication between the old and the new brains. Many psychoactive substances incapacitate the thinking and reasoning portion of the new brain, and the individual reverts to old brain instincts or automatic functioning. The main instrument of the nervous system is the neuron. The neuron is composed of the soma, the axon, and dendrites. Information comes into the neuron through the dendrites and is distributed to the other entities through the terminal or terminals at the end of the axon. Each neuron can make contact with one entity up to 150,000. It is estimated that there is between 100 trillion to 500 trillion neuronal connections in the human brain. Hello? Reese? Neurons are different lengths from fractions of millimeters to the sciatic nerve that can be a meter long and runs from the heel to the spinal column. Sorry, that was my grandson calling. Neurons do not touch, but they do communicate with one another. This communication takes place in the synaptic cleft, a gap between the two neurons. In order for the two neurons to communicate, a chemical messenger called a neurotransmitter must pass between them. The neurotransmitter is housed in tiny sacs called vesicles. Acetylcholine is a neurotransmitter that activates muscles. It works as a vasodilator. It controls mental acuity, memory, and learning. It decreases with age, causing rapid dementia, referred to as Alzheimer's disease. It was the first neurotransmitter that was discovered. Norepinephrine and epinephrine were the second two neurotransmitters discovered. They act as stimulants when the body demands energy. They control hunger, attention span, motivation, confidence, and alertness. Epinephrine equals energy. Norepinephrine equals confidence and feelings of well-being. Dopamine regulates fine motor muscular activity, emotional stability, satiation, and the reward reinforcement pathway. Dopamine is the most important neurotransmitter involved in drug abuse. Reduced dopamine leads to Parkinson's disease. Excess dopamine causes schizophrenia. And the reason I put this picture over here, this is a person who was about to have a psychotic episode. So this is how he drew the cat before his psychotic episode. As he was drifting into his psychotic episode, this is what he drew. And then as he entered the psychotic episode, this is what the cat looked like to him. And then finally this. Histamine controls the inflammation of tissue and allergic reactions. It regulates emotional behavior and sleep. Because it controls inflammation of tissue and allergic reactions. If you have an allergic reaction, we'll give you an antihistamine, which will stop the inflammation and stop the allergic reaction. Serotonin controls mood stability, depression, appetite, sleep, and sexual activity. Mood can be elevated by forcing more serotonin into the synaptic clefts. Enkephalins, endorphins, and dynorphins are involved in regulation of pain, relief of stress, immune response, stomach activity, other physiological functions. This is really kind of funny. This is where endorphins and dynorphins is where the runner's high comes from. And that's the reason I have this picture here. But I don't get runner's high, even though I've been a runner all my life. I don't get runner's high. And it's because there's something wrong with my opiate receptors, my endorphin receptors. but we don't know what it is. But I'm one of 5% of the population of the world. They don't react to opiates. Gamma aminobutyric acid, GABA, is the main inhibitory neurotransmitter. It's involved in 25 to 40% of all the synapses in the brain. It controls impulses, muscle relaxation, arousal. It slows down the brain. Alcohol has a strong effect on GABA, and that's one of the reasons why you get such strong reactions. Glycine is an inhibitory neurotransmitter. It's found in the brainstem and spinal cord. It slows down the brain. It's prominent in protein synthesis. Glutamic acid, glutamine, is an important excitatory neurotransmitter. It plays a major role in cognition, motor function, sensory function, reinforces memory. It's a precursor for GABA. Tachykinin is substance P. The P stands for peptide. It conveys the pain message to the brain from the peripheral nervous system. Enkephalins block substance P, and that's why enkephalins take your pain away. Anandamide has an affinity for the receptor sites that accommodate THC. Found in the limbic system, its integration of sensory experiences with emotion, it controls learning, motor coordination, and memory. It acts as an analgesic, and this is why THC actually functions. It uses the same receptor sites as anandamide. Corticotropin, two forms of corticotropin are ACTH and cortisone. It aids in the immune system. It helps healing. It's part of stress control. Nitric oxide, since it was discovered in 1992, the functions of nitric oxide just continues to expand. It is necessary for the erectile function of the penis. It helps regulate emotions. In too large doses, it can cause cancer and vascular collapse. Psychoactive drugs and neurotransmitters. Alcohol directly affects GABA, metenkephalin, and serotonin. Benzodiazepines directly affect GABA and glycine. Marijuana affects anandamide, 2-AG, acetylcholine, and dynorphin. Heroin affects endorphin, enkephalin, and dopamine. LSD affects acetylcholine, dopamine, and serotonin. Nicotine affects epinephrine, endorphin, and acetylcholine. Cocaine and amphetamines affect dopamine, epinephrine, norepinephrine, serotonin, and acetylcholine. MDA and MDMA, the rave drugs, ecstasy, affects serotonin, dopamine, epinephrine, and norepinephrine. And PCP, phencyclidine, affects dopamine, acetylcholine, alpha endopsychosine. Neurotransmitters attach themselves to receptor cells on the receiving entity, the muscles, the organs, and other neurons that are chemically structured to only accept that neurotransmitter. However, select receptor sites may have different functions for the same neurotransmitter. There are 7 types of serotonin receptors, each of which has a slightly different function. Dopamine has 5 types of receptors, referred to as D1 through D5. The D2 receptor is the site that is used by most psychoactive substances. Each neuron maintains and transmits only one type of neurotransmitter, except for neurons that transmit epinephrine, which may also transmit norepinephrine. However, a neuron may have receptor sites for any number of neurotransmitters. A neuron is stimulated when it receives enough neurotransmitter to create a chemical imbalance in the neuron that forces sodium and potassium gates to open. The increase of positively charged sodium and potassium ions from outside the neuron and the flooding out of negatively charged chloride ions causes an electrical chain reaction to run down the neuron to the axon terminal. At the axon terminal, the electrical stimulation causes the vesicles to release their neurotransmitter into the synaptic cleft, which in turn stimulates a partner neuron. Excitatory neurotransmitters work by opening sodium gates, allowing the sodium into the neuron. Inhibitory neurotransmitters work by opening chloride gates, making the neuron more negative and thus more difficult to stimulate. The stimulation of the neuron by the neurotransmitter is known as the first messenger system. If the neuron is stimulated by another entity, such as a biological or chemical change, it is known as a secondary messenger system. The neurotransmitter can't remain in the synaptic cleft, or the reaction won't stop, so it must be removed. This occurs in one of two ways. The neurotransmitter is chemically broken down. Acetylcholine is broken down by acetylcholinesterase. The neurotransmitter is taken back by the neuron that originally distributed it in a process known as reuptake, which is what happens with serotonin. The number of receptor sites is not constant. When the amount of neurotransmitter decreases, the cell will increase the number of receptors so that as much neurotransmitter as possible finds a place to attach, and this is known as upregulation. If there is too much neurotransmitter in the synaptic cleft, the number of receptor sites will decrease to prevent overstimulation, and this is known as downregulation. This occurs when someone takes drugs. The individual takes more and more of the drug, trying to achieve the same reaction as they had originally. Excessive use of the drug may cause a permanent downregulation, but the downregulation takes place because it's being overstimulated. And because of that, it downregulates. It reduces the number of receptor sites. And if you take these drugs for too long a period of time, it will cause a permanent downregulation. That's what happens with MDMA or ecstasy. The psychoactive drugs work because they act as either agonists or antagonists. Agonists either mimic or facilitate the effects of a neurotransmitter. Nicotine, acetylcholine, alcohol, GABA, LSD, serotonin, THC, anandamide. If this happens partially, it is known as a partial agonist. Antagonists block neurotransmitters. If the receptor is stabilized, making it inactive by a drug, the drug is referred to as an inverse agonist. How drugs affect neurotransmitters? They can block the release of neurotransmitters. Heroin blocks the release of substance P. They can force the release of neurotransmitters, forcing more to be released than is released naturally. Cocaine forces the release of norepinephrine and dopamine. Ecstasy, MDMA, forces the release of serotonin. The drugs can prevent the reabsorption of the neurotransmitter. Selective serotonin reuptake inhibitors block the reuptake of serotonin, elevating the person's mood. The drug can inhibit an enzyme that helps synthesize the neurotransmitter. Blood pressure medicines inhibit enzymes that allow the production of norepinephrine, which would cause high blood pressure if it was allowed to be released in the synaptic cleft. Drugs can inhibit enzymes that break down the neurotransmitters in the synaptic cleft, allowing neurotransmitters to remain in the cleft. Methamphetamine inhibits monoamine oxidase and catecholomethyltransferase, which break down norepinephrine and epinephrine into the synaptic cleft. The drug can interfere with the storage of the neurotransmitter. The drug can do a combination of any of these interactions. While some drugs have desired effects, like making the individual resist fatigue or block pain, that can also be dangerous. Cocaine forces the release of norepinephrine and dopamine, which makes the individual not only stay up beyond normal exhaustion, but respond in an overly excited and sometimes violent manner. Heroin blocks pain and creates a euphoric sensation by attaching to receptor sites in the reward reinforcement pathway, but unfortunately also attaches to the breathing center, depressing respiration. LSD acts as both a stimulatory neurotransmitter and alters the user's perception of external messages, mixing their perceptions so that they may hear images and see sounds. And this is known as synesthesia. Other psychedelics block the action of acetylcholine, creating hallucinations. The body may deal with drugs in several ways. It may become tolerant to it. It may develop tissue dependence. It may have a psychological dependence. It may go through withdrawal. It may break down the drug. It may metabolize the drug. Any foreign substance will be treated as a toxin in the body. The liver and the kidneys will try to eliminate it so that it cannot do any damage. If the individual continues to use the substance, the body will adapt to having the drug present. This adaptation to the presence of a toxin is called tolerance. Tolerance to the drugs will force the individual to take more and more of the drug to get the same effect. A methamphetamine user will achieve a certain level of euphoria and energy the first time they use it. If they use every day for 100 days, by the 100th day, they will have built up a tolerance for the drug that will necessitate a 20 times increase in the amount that they used the first time. In order for tolerance to occur, sometimes the drugs must be taken irresponsibly. If the individual is taking Valium at higher doses than the doctor prescribes, or the doctor is prescribing heavy usage of the medication, the tolerance will be accelerated. Research shows that there are individuals who have built up a tolerance to the degree that they were using 100 to 200 times the standard dosage. Tolerance will return to normal if the drug is no longer used. Types of tolerance: dispositional tolerance. The body accelerates the metabolism of the drug by producing more of the enzyme used to metabolize the toxic substance. The more people drink alcohol, the greater their tolerance because of dispositional tolerance. Thus, the individual will have to consume high levels of alcohol to become intoxicated. Pharmacodynamic tolerance is affected. Nerve cells become less sensitive to the drug. When opioids are used, neurons begin generating fewer receptor cells to the opioid to lessen its effects. The body will also produce cholecystokinin as an antagonist to the drug. Cholecystokinin comes from your gallbladder. Behavioral tolerance: the brain compensates for the effects of the drug by using parts of the brain not affected. A person who is drunk can force themselves to appear sober when necessary. Reverse tolerance: as the drug destroys tissue, the user becomes more sensitive to the drug and can tolerate less and less of the substance. This happens to alcoholics who suffer from cirrhosis of the liver. Since the liver doesn't work as well, a little alcohol will get them drunk because the liver is not operational enough to metabolize the alcohol. Acute tolerance: tachyphylaxis. The brain and body adapt instantly to the toxic effects of the drug. Tolerance to tobacco occurs this way. People who try to commit suicide using barbiturates may experience the same instant tolerance and survive twice the lethal dosage. LSD will not work if two doses are taken close together due to tachyphylaxis. And it's the same way with cocaine. Cocaine's a vasodilator, and if you snort it up one of your nostrils and then a couple minutes later snort some more up the same nostril, the blood vessels will be so closed up that you're just wasting your cocaine. This occurs with opiates and select tolerance. The body develops tolerance to mental, physical effects at different rates. This occurs with opiates and sedatives. With barbiturates, sleep will be induced long after the euphoric effect is no longer present. Inverse tolerance or kindling. The brain chemistry changes so that the person becomes more sensitive to the effects of the drug. With continued use, cocaine and marijuana users will get a minimal effect, and then after months will start to get an intense reaction. In the case of cocaine, it might cause heart attack or stroke. Cross tolerance: if a person develops a tolerance for one drug in a family of drugs, they will be tolerant to other drugs in that family. The opioid family is this way. Tolerance to heroin will make a person equally tolerant of morphine, codeine, or methadone. A person tolerant of Xanax will be tolerant to other benzodiazepines and even the depressant alcohol. A person tolerant to barbiturates will be tolerant to benzodiazepines. Tissue dependence, this is the biological change of the body to adapt to the presence of the drug. This usually occurs after prolonged use. Allostasis sometimes will occur where the tissues and the organs of the body depend on the drug to be functional. In these circumstances, cessation of drug usage will cause dangerous and dramatic withdrawals. In select circumstances, cross-dependence will occur, where dependence of one drug can be alleviated with another drug. Psychological dependence, addiction used to mean that the person taking the drug was tissue dependent on the drug, but with continued research in brain imaging technology, it has been recognized that psychological dependence is an important factor in addictive behavior. The altered states of consciousness that are caused by select drugs can lead to continued misuse to avoid life's problems. It is now acknowledged that psychological dependence occurs before tissue dependence and that the response rate from either is similar. Psychological factors that induce reinforcement, drug automatism. The individual uses the drug aimlessly, unconsciously, and repetitively. Negative reinforcement, unpleasant states encourage drug usage. Smokers will wake up in the middle of the night to smoke to dissipate nicotine withdrawal. Social reinforcement, peer pressure, and the need for social inclusion encourages continued use. Opioid effects, these are the physiological responses to opioids, numbness, euphoria, dryness of mouth, constipation, decreased pulse, low blood pressure, shallow breathing, and inability to cough, pinpoint pupils, and malaise. If somebody comes in unconscious, the first thing we do is look at their pupils to see if they are pinpoint. If they are, then we know that they have overdosed on an opiate. And we'll give them naloxone. Withdrawal symptoms from opioid substances: tactile reaction, pain, psychological reaction, anxiety, depression, or craving, physical excretory reaction, sweating, runny nose, tearing, increased salivation, digestive tract reaction, diarrhea. Remember, we had constipation from its use. Circulatory reaction, hypertension, respiratory reaction, excessive coughing, optic reaction, dilated pupils, muscular reaction, severe hyperreflexes, and muscle cramps, mostly from the loss of fluids, from sweating, runny nose, tearing, the diarrhea, increased salivation. Drug withdrawal is the body's attempt to rebalance itself after cessation of prolonged use of psychoactive substances. Many times for a chronic user, fear of withdrawal is one of the reasons for continued use. Withdrawal often entails muscle aches, pain, insomnia, vomiting, cramps, and on occasion, convulsions. Non-purposive withdrawal, visible physical signs due to tissue dependence, seizures, sweating, goosebumps, or crawling flesh, vomiting, diarrhea, and tremors. Purposive withdrawal, expectation of withdrawal symptoms, causing the rationalization of continued use of the psychoactive substance. Withdrawal effects can be observed whether there is tissue dependence or not. Protracted withdrawal, heavy craving for the drug, even after the addict has been detoxified. This is usually caused from an external cue that causes the subject to have flashbacks to use and withdrawal symptoms. This often causes a recovery addict to relapse. Post-acute withdrawal symptoms, persistent emotional and physical problems that last from 3 to 6 months after recovery. It's unclear thinking and cognitive impairment, memory problems, emotional overreaction, sleep disturbances, motor coordination, dizziness problems, difficulty managing stress, and craving the drug. Sometimes drug abuse is a symptom of other underlying problems. When this is the case, the user will sometimes seek the desired effect by experimenting with drug usage. Replacement, they'll replace the desired drug with another intoxicant. Multiple drug use, they'll use the use of different drugs to alleviate differing symptoms. Cycling, using a drug intensely for a period of time and then abstaining to lower tolerance or allow the body to repair. And this is what Amy Winehouse did. Amy Winehouse drank herself to death, but she was a heavy drinker. But what she did, she abstained for a couple weeks and built up, and her tolerance lowered, and then she drank as much as she would have otherwise, and she poisoned herself. She died of alcohol poisoning. Stacking is using two or more similar drugs at the same time to achieve a specific effect. Mixing, using drug combinations to acquire a new effect. This is what killed John Belushi and I can't think of his name. Speedballs. They were using speedballs. Cocaine and heroin, as dumb as that sounds. Marijuana laced with cocaine. They used to call those Thai sticks in, well, it was marijuana laced with heroin. Thai sticks in Vietnam. Ecstasy and LSD, X and L, methadone and Klonopin. It mimics heroin. Sequentialing, going from one addiction to the other. This can either refer to drug sequentialing, drug replaced by a compulsive behavior, or one compulsive behavior replacing another. I had a friend who was an alcoholic, gave up alcohol and picked up gambling. And so if he gets a hold of any money, he gambles until it's gone. Morphing, using one drug to counteract another. A cocaine user drinking alcohol to come down, using coffee to come down off of a drunk, using methamphetamine to function during a heroin high. Level of use is determined by the amount used, the frequency of use, the length of time psychoactive substances have been used, the impact the drug usage has on the user's life. Categories of usage include abstinence, experimentation, social recreational use, habituation, abuse, and addiction. Many individuals cannot choose their level of drug use, but are at the mercy of the psychoactive properties of the drug being used. Abstinence means that an individual does not use any psychoactive substances except accidentally. Even if the person has a strong hereditary or environmental susceptibility for compulsive drug use, by never starting, they never get hooked. These individuals might display other compulsive behaviors such as gambling, overeating, compulsive internet use, and excessive sexual behavior. Research shows that individuals who wait until they are 18 years or older to experiment with alcohol, nicotine, or marijuana are less likely to use these substances as gateway drugs for more dangerous substances such as cocaine or heroin. However, if the individual experiments between the ages of 10 and 12, they are more likely to use the early experimentation as a gateway to more serious usage. Individuals who don't start smoking until age 21 are very unlikely to develop an addiction to nicotine. Anyone who doesn't try an addictive substance until age 21 will probably not become addicted. Experimentation with the psychoactive substances occurs because of curiosity, but no pattern of usage is developed, and there are no negative consequences from the experimentation unless usage leads to injury, accident, or illness, the individual has an exaggerated reaction, a pre-existing physical or mental condition is exacerbated, the user is pregnant, the individual is arrested for use, heredity or environment dictates addiction, previous addiction with other substances leads to relapse. Social recreational users may seek out a drug for the effect, but no permanent pattern of use is developed. Usage can be controlled for these individuals as long as they do not develop drug-seeking behavior. Habituation, the individual has developed a pattern of usage, but there has been no negative effects on the individual's life. This is referred to as habituation because though there is no increase of usage, the usage pattern indicates that there is definite craving for the substance. Abuse, the individual continues to use the substance despite the negative life consequences that have occurred. These consequences can be personal, like relationships, problems in their social lives, financial, legal, continued use despite arrest for possession, medical, personal health, alcoholic with diabetes, heavy smoker with emphysema, the cocaine user with hypertension, work or school-related emotional stability, LSD user with mental instability. Addiction, the individual become between abuse and addiction is the compulsive behavior of the addict. Addiction is the classification if the individual has no control over duration of usage or amount used. The individual has been unsuccessful at control. They spend an inordinate amount of time obtaining drugs or recovering from usage. They limit social, occupational, or recreational activities for use. They continue use despite physical, social, relationship, or psychological problems. They use in the morning for a jump start on the day. They defend their drug usage with anger or even rage. They experience withdrawal when unable to use the drug. They must increase the amount used to obtain the desired effects. Addiction comprises the 4 C's: control, loss thereof, compulsive use of the drug, craving the drug, and continued use of the drugs. The American Psychiatric Association has identified substance use as a mental illness since the printing of their first diagnostic and statistical manual of mental disorders in 1952. The current DSM-5 divides substance abuse disorders into 2 general categories: substance-related disorders and substance addictive disorders. The DSM-5 deals with several drugs, which include alcohol, stimulants, cannabis, also known as marijuana, cocaine, hallucinogens, inhalants, opioids, anxiolytics, sedatives, hypnotics, caffeine, and tobacco. The addictive disease model. This model of addiction sees addiction from the medical point of view, that addiction is a disease. It's chronic, it's progressive, it's relapsing, it's incurable, it's potentially fatal. This model assumes that the addiction is caused from genetic irregularities in brain chemistry and anatomy that are triggered by certain drugs. Research shows that heredity influences drug use and addiction as much as 40 to 60%. Compulsive drug use with prolonged intoxication with a need to continue use, inability to control use, inability to stop use despite physical, mental, or social problems, repeated attempts to control use, increased intake over time, it's incurable, pathological reactions such as blackouts or dramatic personality changes. The behavioral environmental model, this theory purports that negative environmental factors such as abuse, anger, and peer pressure may cause people to seek, use, and sustain dependence on substances. This model emphasizes the progressive nature of the 6 levels of drug use: abstinence, experimentation, social recreational use, habituation, abuse, and addiction. The academic model, the addiction occurs when the body adapts to the toxic effects of the drugs at the biochemical and cellular levels. Natural balance has been thrown off, causing 4 physiological changes: tolerance, tissue dependence, withdrawal syndrome, and psychological dependence. Diathesis stress model. This model was first developed to explain the causes of schizophrenia. It is a combination of the addictive disease model and the behavioral environmental model. Diathesis means a predisposition or vulnerability to, and in this case, the individual may have a genetic and environmental predisposition to drug addiction. Stress triggers the drug need, and the stronger the diathesis, the more likely that the individual will drift into addiction. Heredity. Researchers have found that genetics does influence addiction, but that there are over 100 genes that have something to do with drug abuse. Receptors, gene transcription factors, enzymes, neuropeptides, G proteins, transporters, all of these are factors in heredity. Looking at twin studies, Goodwin found that if identical twins separated at birth, were most likely to choose the addiction or substance patterns of their abstinence patterns of their biological parents over their adoptive parents. Similar research found that 61% of the sample maintained nicotine dependence similar to their biological parents, and 55% displayed the same alcohol dependence of their parents. Researchers looking at males in treatment found that children with one alcoholic parent had a 34% greater probability of being an alcoholic than the male children of a non-alcoholic. When both parents were alcoholics, the child had a 400% probability of being an alcoholic. If both parents and a grandfather were alcoholics, the individual had a 900% greater probability of being an alcoholic. 28 million Americans have one parent who is an alcoholic. Researchers have found that 70% of the severe alcoholics have a dopamine-controlling gene called DRD2A1. Many social drinkers, only 30% have the gene. Among the social drinkers, only 30% have the gene. When this gene is present, the individual has fewer dopamine receptor sites in the nucleus accumbens. Since many of the missing sites are D2 sites, the individual will need more intense stimulation to feel satisfaction. DRD2A1 gene seems to indicate the tendency for any problem behavior, as it has been found in other addictive behaviors other than alcoholism, gambling, ADHD, aberrant sexual behavior, overeating, antisocial personality disorder, and Tourette's syndrome. Some refer to this gene as the compulsivity gene and the process as the reward deficiency syndrome. People with DRD2A1 tend to consume large quantities of psychoactive substances before becoming intoxicated and then have greater dysfunction when they do get drunk, such as blackouts and brownouts. There are also genes that make it less likely that a person will develop an addiction. DRD4 gives the individual an excess of dopamine, which has been shown to play a role in spiritual acceptance, making it less likely that the individual will accept the addictive lifestyle. Environment, interactions with the environment, but especially the home environment, make new nerve cell connections and alter the neurochemistry that the individual was born with, determining if and how the individual will use psychoactive drugs. Factors in the environment: physical, sexual, emotional abuse, stress, love, poverty, living conditions, family relationships, nutritional balance, healthcare, neighborhood safety, school quality, peer pressure, the internet, and television. The environment molds the brain's architecture and neurochemistry, determining how the individual will react to outside influences. This is especially true in the first 10 years of life. The brain develops from the front to the back, meaning that adolescents are more prone to poor impulse control behaviors like substance abuse. Recent research shows that it takes at least 20 years for the brain to become hardwired, and the prefrontal lobe continues to grow until around the 44th year. Memories are established through a network of neurons involving select neurotransmitters: norepinephrine, serotonin, acetylcholine, and dopamine. The more an action is repeated, the more likely the individual will remember it, unless the memory is emotionally intense, in which case the memory has a stronger memory network. Hence the intrusive memories of a traumatic event that may end up causing post-traumatic stress disorder. Children growing up in a chaotic environment where there is excessive emotional pain can deal with the pain in several ways. They can face the pain and try to deal with it. They can find people to help them deal with it. They can accept what happened. They can run away. They can become hyperactive. They can become angry and fight. They can make jokes. They can develop an addictive use to drugs, food, gambling, or sex. If the stress continues over time, the counterbalancing behavior will become ingrained in the brain and becomes part of the individual's personality. In the future, when an unwanted emotion arises, they will be drawn to the simplest solution: the counterbalancing behavior. They'll run away, they'll become hyperactive, they'll become angry and fight, they'll make jokes, they'll become addicted. The people most likely to abuse drugs, stress is common in the home, abuse of some kind occurs in the home, drugs or drinking are commonly used in the home or among the individual's peers. Healthy ways of reacting to stress and or anger aren't learned. Society tells the individual that psychoactive substances are normal and an acceptable way to solve life's problems. Living in a community where access to legal and illegal drugs are easy, there are pre-existing mental conditions exacerbated by the negative home environment. Healthy brain chemistry can't be maintained because of poor nutrition. The media inundates the individual with advertisements supporting the use of selective psychoactive substances. One belongs to a peer group where excessive use of psychoactive substances is normal. Psychoactive drugs, heredity, and the environment may prime an individual for addictive behavior, but it is a psychoactive substance that they decide to use that will determine the impact the addiction will have on their lives. Excessive drug use will not only make the individual more susceptible to more and more use, but more vulnerable to other stronger drugs. Select psychoactive substances, particularly methamphetamine, cause the death of brain cells through a process known as apoptosis, where damaged cells are programmed to kill themselves. Nicotine produces an immediate long-term change in the levels of dopamine and norepinephrine, which leads to the faster development of tolerance and dependence. Some drugs have a greater power to positively reinforce and therefore compel to a continued use, such as cocaine and heroin. Compulsive obsessive behavior mimics drug use, which in turn causes the brain to be rewired. Gambling, eating, shopping, sexual activity, video games, and internet use. Research with video game usage has shown that dopamine is released in the reward reinforcement pathway when an individual plays video games, an amount equivalent to the methamphetamine usage. Compulsive behavior, PET scans of compulsive eaters has demonstrated that there is a decreased number of dopamine D2 receptor sites in the nucleus accumbens. Research shows that between 25 to 63% of compulsive gamblers have been dependent on alcohol or other drugs in their lives. It has been demonstrated that gambling creates brain disruption similar to drug or alcohol usage. The drug that pushes the individual the hardest and quickest into addiction is smoking nicotine in tobacco. The drug that pushes the individual the second hardest and quickest into addiction is smoking crack cocaine. The drug that pushes the individual the third hardest and quickest into addiction is smoking or injecting heroin. The drug that pushes the individual the fourth hardest and quickest into addiction is injecting methamphetamine. The drug that pushes the individual the fifth hardest and quickest into addiction is snorting cocaine. The drug that pushes the individual the sixth hardest and quickest into addiction is ingesting opioid painkillers. The drug that pushes the individual the seventh hardest and quickest into addiction is ingesting any amphetamine. The drug that pushes the individual the eighth hardest and quickest into addiction is ingesting sedative hypnotics. The drug that pushes the individual the ninth hardest and quickest into addiction is drinking alcohol. The drug that pushes the individual the 10th hardest and quickest into addiction is smoking marijuana. The drug that pushes the individual the 11th hardest and quickest into addiction is ingesting PCP. The drug that pushes the individual the 12th hardest and quickest into addiction is ingesting caffeine, not especially coffee, but caffeine. The drug that pushes the individual the 13th hardest and quickest into addiction is ingesting MDMA, also known as ecstasy. The drug that pushes the individual the 14th hardest and quickest into addiction is ingesting LSD. The drug that pushes the individual the 15th hardest and quickest into addiction is ingesting peyote. And that is the end of the chapter. So next week we'll tackle something. I think that we're tackling uppers next week.